So let's get started. I want to welcome you all to the fourth podcast for the POCUS Journal. It's really exciting to have Dr. Nathaniel Reisinger and Dr. Abhilash Koratala on with us this evening. We're here to discuss the very exciting special issue of the POCUS Journal that came out this month, and it's the kidney issue. You can see it at POCUSjournal.com, where the full access is available. Like all of our issues, it's open access for viewers and free and open access for the authors to publish their manuscripts and cases and research. And without further ado, I want to ask Dr. Nathaniel Reisinger to introduce himself and also tell us about how he fell in love with point-of-care ultrasound.
Thanks, Jamie. Really glad to be on the podcast. Just delighted that we were asked to put together this issue. I am assistant professor of clinical medicine at Penn Medicine here in Philadelphia, where I serve as co-director of the internal medicine point-of-care ultrasound fellowship and director of point-of-care ultrasound for nephrology. I did our fellowship here just a few years ago. I first got interested in point-of-care ultrasound as a resident. I had an attending at my institution who was really enthusiastic, bought himself an early pocket ultrasound and was scanning back in days dinosaurs roamed the earth. I think my first moment really where ultrasound became very clearly critical was actually a patient with AKI. I was a resident in the CCU, in the coronary care unit, and we had a patient. I wrote about this in our little preface. Who came into us with rising creatinine. That was really the only reason he came to the ICU. His pressures were okay. He was maintaining well, but his creatinine went from 1 to 3 over a single weekend. And the fellow, cardiology fellow I was on with, put the probe on his chest right when he got to the CCU, and despite my physical examination being completely unremarkable, he had a massive pericardial effusion from a pacemaker placement, a bloody pericardial effusion. Went to the OR and made an astounding recovery. So that was kind of my first my love story with point of care ultrasound, and it's been whirlwind romance since that time. I'll let Abhi introduce himself as well, and he can tell you about how we came to be fast friends and frequent collaborators.
Hi, thank you. Thanks for having me in the podcast, and nice to be with you. Well, I mean, I'm one of the nephrologists at Medical College of Wisconsin, and I'm the director of clinical imaging for nephrology. I've been doing point of care ultrasound for the past few years. Started when I was a fellow at the University of Florida. My story is nothing as fascinating as Dr. Reisinger's, but I initially started learning kidney ultrasound because I thought it's something cool that nephrologists being able to do it and also read it instead of relying on radiology and following up the note again while examining the patient. You could do something, and eventually I realized in nephrology practice, we deal so much with volume status disorders, that is bedside assessment of hemodynamics. So then I gradually learned lung ultrasound, IVC, Doppler echocardiography, and so on. So yeah, that's what I've been doing, yeah.
Outstanding. It's so great to hear your stories. And I meant to mention that we're so fortunate that the two of you were recruited to be the nephrology or kidney section editors of the POCUS Journal. And, we're so lucky to have you both on our editorial board. And, as co-editors of this special issue, you took on a lot of responsibility, to organize the content and find peer review, and so much work that was put in to get this kidney issue where it is. I wondered if you could just take a moment to tell us a little bit about sort of the gap that this issue fills, sort of the background about how the kidney issue came about, and a little bit about how it's going to be co-listed on the Renal Fellows Network. For our listeners who may not know what the Renal Fellows Network is, tell us all about that.
Yeah, I'll get started. Me and Abhi go way back. I think we first met at the NKF Spring Clinicals in Boston in 2019. We both did fellowships through the Nephrology Social Media Collective, which is exactly as nerdy as it sounds. It's a bunch of nephrologists from all over the world who have been coming together to put together free open access medical education for nephrology fellows and for nephrologists since 2015, actually. So we were, I think I was the class of 2017 and you were the class of 2018.
Yeah, I guess I'm 1 year after you.
So we had a lot of the same mentors, and I think from a very early time realized that among nephrology fellows there's this huge demand for education, for free education and point of care ultrasound. I'll let you take it over because I have a needy cat here.
For those who don't know, there's a delightful cat who's joining the podcast. If you can't see it, Dorian Gray, Nathaniel Reisinger's cat, who joined the podcast briefly. Abhi, any further background on the kidney issue, sort of how you came up with it to make a focused issue on this, sort of the foresight to bring it all together in one location?
Yeah, I mean, I guess like you and Nathaniel have initially started this, the initiative. And there was an immense need for like talking about multi-organ ultrasound in nephrology. And a lot of people still don't know that nephrology-related ultrasound extends beyond kidney ultrasound. And there is definitely interest and among both trainees and also practicing nephrologists to learn point of care ultrasonography and to know more about it. But there aren't many resources available for hands-on training, and also there weren't many published articles specifically related to nephrology. And that's how I guess this started, because POCUS journal is essentially dedicated to point of care ultrasonography in all specialties. And
piggybacking on that, Abhi, I'd say that since the 90s, really, there's a big movement among nephrologists centered around Charlie O'Neill and colleagues and his trainees at Emory, who since I think 1992, he's been doing his own comprehensive ultrasounds of the kidney specifically. And I think we both attended his weekend course on point of care ultrasound. We both, I think as fellows, were inspired by what he's doing, really seizing the diagnostic tools back from the subspecialists and putting that in the nephrologist tool belt. And, to a big extent, I think part of our own thinking is really influenced by Charlie O'Neill. He, I think, is kind of the father of diagnostic kidney ultrasound performed and interpreted by nephrologists. And the way I envision, and correct me if I'm not speaking for you, kind of our own our own practice is moving that into the point of care realm. Is instead of doing comprehensive studies, interpreting them and billing them, being your own radiologist. This is performing studies at the point of care in terms of multi-organ assessment, not moving beyond just the comprehensive kidney exam, but looking at other organs, looking at the heart, looking at the lungs, getting other clues about a patient in shock, or learning about what their volume status is. And so I think a big part of who we are was being influenced by that prevailing notion, but building on that and making it more accessible for nephrology fellows across the country.
Outstanding. I really am so inspired to hear, the common threads that you mentioned. I have to look into some scholarship by Charlie O'Neill. I'm sure it's dating back quite to the beginnings of point of care ultrasound in even in emergency medicine. I wanted to just comment that as a non-nephrologist, I think one of the parts that really excites me about your taking the charge here is that so much of this is applicable not only to internal medicine, hospital medicine, outpatient general medicine, critical care, emergency medicine, pediatrics. That there's so much that all physicians in many settings really relate to so many of the topics that you cover here in the kidney issue of POCUS journal. So you mentioned already integrative volume status assessment. There's an article on 65 to 77 discussing those topics. Acute kidney injury, of course, is incredibly common in hospitalized patients. And I think running the spectrum to some more nuanced nephrology specific topics like hemodialysis, vascular access, an article on page 105 to 109 of the issue is more pertaining to nephrology fellows and nephrology attendings. But I think so much else covered in this article is so applicable to many other POCUS users in their practice. I wanted to also sort of break from our original itinerary here to ask you a question that you made me think of. That this really is an up and coming area in nephrology, and I wanted to ask you both if you that when you see perhaps a colleague who trained in an era where point of care ultrasound was not a part of their training, what do you say to the nephrologist who tells you, listen, I know you like this gizmo, but I'm pretty good at working through a hyponatremia case without it. I'm pretty good at volume status exam or determining volume status based on physical exam and other data points, laboratory exam and imaging, et cetera. What do you say to them to answer the question of why should they learn these skills?
You want to go first, Avni?
Yeah, go ahead. So sorry, I was no, when somebody asks why do you need point of care ultrasound, it's most likely lack of exposure or lack of understanding of the philosophy of point of care ultrasound. Most of the senior physicians still look at it as a separate imaging entity where you wheel the machine and stuff, instead of seeing it as an extension of physical examination. And the real philosophy of point of care ultrasonography is being an extension of physical examination, while you're taking history of the patient and performing conventional physical examination, analyzing your laboratory parameters and doing chart review. At the same time, you have some focused questions in the mind and you get answers. And once more people start to realize that and how conventional parameters are flawed in various circumstances, and how adding a new parameter can provide adjunctive value to the existing parameters is the key. And when somebody is not accustomed to the point of care ultrasound, the idea itself, they see it as a threat, or they see it as an entity that's trying to replace the conventional examination. But that's definitely not the case, and we want to emphasize that it should be a part of the conventional assessment. And and as more and more medical schools start teaching point of care ultrasonography to students, very soon you will encounter residents or nephrology fellows who are already trained to some extent in point of care ultrasonography. And just because they are trained in ultrasound, it does not mean their technique or the interpretation is perfect. And as an attending physician, you should be in a position to at least interpret those images. So that would invert the teaching pyramid, and that's going to create some confusion in the decision-making process. Yeah, that's what is my impression.
I want to hear Nathaniel's answer, but I did want to respond. I think one point that you made about sort of value of doing your own exams, I think both of you were mentioning about the timing, and I think that's a strength of point of care exam, is that a patient may not have hydronephrosis on admission, but 12 hours later, they may have obstructive renal disease, and doing serial radiology performed, transporting the patient to radiology to do those exams for something as simple as looking for hydronephrosis is impractical and also inconvenient and creates delay. And so I think it's just such a good example. There's so many applications in nephrology and in evaluation of the kidney, but something like ruling out obstructive disease or evaluating for obstructive disease post-renal cause of AKI is so so helpful and so common. I just wanted to make that point. Nathaniel, tell me what your go-to answer is when you and I don't want to pin this only on senior faculty, but when a colleague in nephrology or another field says to you, well, why should we learn all these new skills in point of care ultrasound? What's wrong with our current or the old practice of nephrology? What do you tell them?
Yeah, Jamie, to answer that question, I want to point out behind you and to your right is a picture of a pipe. This is a work by Renee Magritte, The Treachery of Images. And there's an inscription under the pipe that says in French, "This is not a pipe." And I want to hone in on that because I think it's emblematic of why point of care ultrasound is important. Back when René Laennec first invented the stethoscope, it was very early on in medicine, and pathology was still being defined. A lot of what we now think as canonical as manifestations of disease were defined by the tools that they had at the time to detect pathology. And I think Abi really hits the nail on the head here. He says, point of care ultrasound is your physical exam. It's your new physical exam, and I don't think that we're going to prove at any time in the future that point of care ultrasound is superior to traditional imaging. But over time, as more and more physicians use it, in 2014, 62% of internal medicine, of med schools had a point of care ultrasound curriculum. The next generation of practitioners are going to be using point of care ultrasound, and the way that we define disorders is going to fundamentally change. And if you're not, if you're not at that forefront, then you're on the menu. Your days as a practitioner are numbered, unfortunately. And I'm not sure it'll happen in 5 years or 10 years, but I think people who are not keeping up with the times with point of care ultrasound are going to find how they're interacting with the patient and how they're interacting with medicine to be inadequate. And I would add that I kind of want to shift focus here. Nephrologists have so many points of contact with internal medicine. You check a basic metabolic panel, and 6 of those 7 numbers. If there's something wrong with those numbers, if they're too high or too low, those are reasons to call a nephrologist. The kidney is the canary in the coal mine of organs, both acutely and chronically. Patients on the inpatient side who have septic shock, if they're hypotensive, if they've undergone anesthesia and their blood pressures dip a little bit, often a rising creatinine is the first manifestation of hypoperfusion injury. Likewise, on the outpatient side for your primary care practitioners, the diabetic, the hypertensive, the person with ApoL1 disease, the kidney is the canary in the coal mine. It's the first end organ manifestation that we're often seeing. So we have a lot of contacts with our internal medicine colleagues, and I think to practice internal medicine is by definition to practice nephrology. And what I want to really get out of the relationship with my hospitalists, with my primary care practitioners, is a strong relationship where we can co-manage patients together, because we're going to be seeing the same patients. We're going to be seeing those dialysis patients and patients with chronic kidney disease over and over again, because they have such high event rates for cardiovascular disease. So I think those are just a few of my soapboxes.
Outstanding. I really can't tell you how inspiring it is to hear your commitment and your vision. Both of you. It's awesome. I do want to ask about procedures. I think nephrologists practice in so many different settings. I'm sure there are some centers where nephrologists don't do their own vascular access, either for hemodialysis, arm access or temporary catheters, and don't do their own biopsies necessarily. But I think there are centers and nephrologists who choose to maintain those skills. So I think it does go without saying, but I think it's worth just mentioning that procedural safety for renal biopsy and temporary dialysis access, and the standard of care for ultrasound to be incorporated in those procedures. But if you had any other points about the procedural nephrology element, it wasn't explicitly covered in this issue, but it comes up, of course, in a few articles. But any thoughts there on point of care ultrasound in the nephrologist toolkit for procedures?
Yeah, I mean, it's very true that that procedural training or performing procedures is very heterogeneous among nephrologists, and it varies by institution, it varies by academic setting versus private setting. Regardless, point of care knowing access related point of care ultrasonography is still important in certain situations where you want to know if the access has clotted, or you want to know if the patient has pseudoaneurysms, or the needle cut too deep and the patient complains of pain. Does the patient have hematoma? These are all like very small things that we encounter in day-to-day life practice, and having a quick way to look at those will be very helpful. And also, like, recently there is so much interest on ultrasound guided cannulation in the dialysis units, and even bigger dialysis companies are getting vascular probes to so that they can train their staff to cannulate difficult patients. So that's an exciting area. And biopsies, not everybody does biopsies, and most of the places where they do biopsies, they do under with the help of radiology technician. The reason being, we typically do not do bedside biopsies. If you do bedside biopsy at the patient's bedside, you can use your own machine and do it. But if the hospital does not allow that and they want you to use the radiology suite, then obviously you're going to use their support. That's how procedures go. And obviously for internal jugular catheters, it's well known the rate of complications is much lower with ultrasound standard.
Right. I do want to point out in the article that's on page, sorry, one sec, the page 105, point of care ultrasound of the hemodialysis vascular access. That's by Gomes and colleagues. The article covers some of the topics were brought up about looking at arm access with point of care ultrasound. I will say that from my standpoint, I think that a nephrologist who might say, well, I'm a nephrologist, I don't want to put the time, I don't need to put the time into say cardiac POCUS or thoracic evaluation by point of care ultrasound, even though as Abhi pointed out, so critical for integrating the care of the renal patient. But I can understand a nephrologist saying they didn't want to undergo that type of training, but I think that there's so much clearly that a nephrologist in practice or a nephrologist in training can do just in evaluating the kidney, bladder, and dialysis access. So the other article I wanted to mention was about the point of care ultrasound in evaluating the post renal biopsy bleeding, and that's by McCall and colleague at Vanderbilt. On page 33 of the kidney issue, they go through monitoring post renal biopsy bleeding, which, as you know, is clearly can be a devastating complication in renal biopsy. So many applications that aren't competing with historic volume assessment, just renal specific applications of point of care ultrasound abound. Nathaniel, did you have anything to add about sort of your view on procedures or nephrology specific applications for point of care ultrasound?
Yeah, I mean, I think the kind of the 100-pound gorilla in the room is that nephrologists are pulled in a lot of directions, and a lot of us are not doing our own access, our own temporary hemodialysis access. We're not, by and large, once we're going into practice, particularly private practice, physicians are not doing biopsies. It's I think 70% and 80% are not doing dialysis lines and are not doing kidney biopsy, and it's questionable, in my mind, whether that's a critical skill going forward to teach our nephrology fellows. When we have things like Gomes and colleagues point out, just the other day at my dialysis unit, a patient had their fistula infiltrate, and the nurses were going to send the patient to the hospital. I happened to be there. I happened to have my ultrasound and found another segment of the access where we could safely cannulate, and prevented the patient an admission. In a patient who had been into the hospital 4 or 5 times already that year, that's a huge victory. And so I do think to some extent, choosing our battles is very important, and I think it's going to be very context driven. It's going to be really driven by how your practice is behaving, whether you learn that particular skill or not. And I do think ultrasound of the hemodialysis vascular access in terms of guidance for cannulation, for troubleshooting. We also look at a pseudoaneurysm in another article I wrote with one of our ultrasound fellows here. I think it's going to be very dependent on the specific practice, but that's a hot area of debate in nephrology right now.
Right. Really a nice segue into another question about a review article you wrote with Noel Northcutt at Denver Health. this is on page 88 of the issue, the nuts and bolts of I hope I'm saying this correctly, a POCUN or a POCUN program. So that's point of care ultrasound and nephrology, a POCUN program. We were discussing about what to respond to the naysayers. We're talking about all these great applications. One thing in my mind is if I was a nephrologist listening to this podcast, I'd want to know, well, how do I build a program? Because one of the case you just illustrated, about reducing hospitalization, that's something that's hard to capture in a study setting, to prove that dialysis access evaluations by outpatient nephrologists in the dialysis center reduced hospitalization would be very difficult to do in a prospective study, cost prohibitive and other things. But I think that it's just common sense, as you pointed out, but that it's very difficult to capture that patient experience in of not having to go to the hospital, wait in the ER and spend 3 days in the hospital unnecessarily. That those financial component aside, the patient experience is one of these wonderful aspects of point of care ultrasound. And I just wondered, this article is fantastic. Anyone who's interested should check it out about the sort of the nuts and bolts of building a program, but sort of tying together some of these threads we mentioned about the applications and how to change hearts and minds. I wondered if you had some highlights from that review that you wanted to share, or just some advice to folks around the country and around the world who are building programs. They have a device, they have some, they're undergoing some training. There are many issues that are related to nephrology specifically, but I think are also in other POCUS programs. We don't have time to get into things like documentation and billing, necessarily, but I've just wondered if you had any, advice to the nephrologist trying to build a POCUN program around some of the issues we talked about.
Yeah, I'll field this. I helped the outstanding and irascible Noel Northcutt write this article, or I should say I contributed. So I think this very interaction is what is fundamental for building a POCUN program, building a point of care ultrasound and nephrology program. And me and Abhi are part of the POCUN Society, the Point of Care Ultrasound and Nephrology Society. President Dan Ross at Northwell Health has done an excellent job in organizing nephrologists who are interested in point of care ultrasound, and has organized a lecture series around that. But fundamentally, what's so important, what really struck me about writing this article is the number 1, 2, and 3 thing that you need for building a point of care ultrasound program is to steal resources from other groups. And that is exactly, I think, my career in a nutshell. And steal, but is kind of a strong word, but really to use the resources that exist around you and then give back to those programs. Emergency medicine, critical care, hospital medicine, obstetrics, you name it. A rheumatologist at my institution has recently started a point of care ultrasound program, and to build a program in nephrology is to share those resources. And I think we really talked about this a lot, is we build on the experiences of those who come before us. And I think I owe so much to my own, particularly in emergency medicine. And I can name several people who helped me along: Nova Panay Bianco, several members of the POCUS Journal editorial board, Wilma Chen and Cameron Baston, helped me become the person who I am today, and helped build our point of care ultrasound in nephrology program at Penn. I think it's by necessity a collaborative discipline, because you need everything you need are things that people are already thinking about. Getting the the ultrasounds themselves, building image archiving program, dealing with how to legislate these studies on a global level, whether you need a image archiving software, cloud-based system, how to handle just the engineering. So we really go in depth, I think, and this is an excellent article on everything you need. But ultimately, the answer is, it takes a village, and that village exists already around you for nephrologists from the people who went before you.
Incredible. I think the other details in the article, sort of the how-to, the nuts and bolts are there, but what a great overview. And I think anyone listening who is in doubt of whether they can do it, hearing you talk about your success in building a POCUS program, I'm sure they'll see a path forward. Abhilash, do you have anything you wanted to add about sort of program development, in addition to the article? If not, I had another question for you.
Yeah, the article pretty much covers everything, and it's so nice that it even adds a paragraph on how to develop a program during pandemic with the challenges of not being able to conduct in-person lectures and stuff. So that's great, and I very much agree that the whole village is around you, and you have nephrologists from other institutions who have already done this, and also from within the institution there might be other specialties such as emergency medicine or critical care where you can go for advice and go from there. Yeah.
Outstanding. I wanted to ask Abhi about a little bit about Vexus. I think that it's anyone who follows you on Twitter at NephroPOCUS knows this is a topic that you adore and are an expert in and great at teaching. And I just wanted to ask, because I think some of these applications include the POCUS use of ultrasound in a way that diagnostic radiology does or other modalities do already. So that's like doing cardiac POCUS it's a version of echocardiography in a way. Doing a hydroscan to rule out hydronephrosis is borrowing from diagnostic radiology in a POCUS fashion. But Vexus is I think something that some of our listeners may not have heard about, and that's in a case file from the kidney issue, page 17 to 20, where you cover that in full. But I did want to make time to for you to tell us a little bit about Vexus, your favorite topic, in a few minutes. But just to introduce that, and
you have 1 minute. Go.
Yeah, I mean the key point of hemodynamic assessment is to look at the whole hemodynamic circuit, right? It's not just looking at the inferior vena cava or just doing lung ultrasound and trying to make some clinical decisions. And some patients can have chronically dilated inferior vena cava, and sometimes when you're in internal medicine practice or nephrology practice, it's not only about the diagnosis, but also how you follow on the patients and how you can use these POCUS parameters to guide your therapy. And say if you're relying on inferior vena cava for the right atrial pressure, like I said, some patients may have chronically dilated IVC. And also, how much can you rely on the change in the diameter or the change in the size of the IVC with the respiration on a day-to-day basis. And as the patient gets better, probably the patient can sniff harder, and that changes the strength of breath and alters your comparison. But regardless, so it suffers from so many technical limitations. So Vexus in that sense adds a great way to quantify venous congestion. That is how the end organs are feeling the congestion. That way you can assess whether the patient has congestive nephropathy, or even if the patient has ATN, you did urine microscopy and found muddy brown cast, it does not mean that the hemodynamic insults are gone, right? So the patient can still have ongoing venous congestion, which will impair further renal recovery. So for that, having this additional modality will help you. Like you said, it's all piecemeal, right? So cardiology does echocardiography, and radiology does kidney ultrasound, And either radiology or in some institutions, a separate vascular lab does this Doppler ultrasound studies, which you order as right upper quadrant scan or something like that. So if you're a nephrologist or an internal medicine physician who is able to combine all these pieces together and perform at the bedside, that's the greatest advantage. And obviously, the change in these waveforms allows you to monitor the response to therapy in both the case files. And one case file is like very much detailed, following the patient with multiple follow-ups. And there is another case file which talks about a patient in ICU who required ultrafiltration, who was initially thought to be hypotensive because of volume depletion or over-diuresis, but doing VEXA scan has revealed severe congestion. And also the interesting part in that case file was that the patient had a D-shaped left ventricle because of the interventricular septal flattening, which is because of right ventricular dilatation with the fluid overload, which was possibly contributing to hypotension. So this is a case of hypotension which would improve with fluid removal. So that's kind of VEXAS in a nutshell. Basically, it's quantifying venous congestion and allowing you to monitor the changes with therapy.
And I want to piggyback on what you said, because you said it so beautifully, but I think you buried the lead. When we're on the inpatient side as nephrologists, we see about two disorders that cause AKI. We see hemodynamic injuries at the level of the glomerulus. Sure, you can have someone who's truly hypoperfused, who is in shock, has a lactate, maybe it's septic, maybe it's hypovolemic, or they got a rapid sequence induction for intubation and dropped their pressures markedly. Maybe they have a failure of autoregulation at the level of the glomerulus, but it's so uncommon for us to see parenchymal kidney injury apart from generic hemodynamic tubular injury. We just AIN even less than 10% of cases. You're not going to see a de novo GN almost ever arising while the patient is in the hospital. And what I think is so underrecognized is that all of these patients with a cardiorenal syndrome, the mechanism of injury is not glomerular hypoperfusion because of reduced cardiac output, but it's congestive nephropathy. It's high renal venous pressures, which are diminishing the glomerular perfusion. So I can't understate how important it is in helping us not just recognize but prove to other people that these patients need diuresis when they have renal venous congestion, when they have nephrosarca. And so I find it so valuable, and I think Abhi is one of the most humble people and one of the smartest people I know, but I want to drive that home to everybody. It's so important what we do.
Well, I whenever I hear you talk about how you use Doppler for the VEXAS exam, it reminds me, as a let me say not yet VEXAS user, it reminds me of how I talk to non-POCUS users about how great POCUS is, that they need to get with the program here. And so it's a nice reminder for me, and I'm sure many others too, certainly as handheld and other devices are updated, I think, to include the tools, the software, and my everyday device doesn't have spectral Doppler, so those are necessary for the VEXAS exam. I wanted to ask one more question before we get into sort of future directions and then some of the other plugs you mentioned about the venues that this content is going to be distributed on. I wanted to ask just briefly about incidentalomas. There's a great article, Nathaniel, you co-authored with your folks at Penn on starting on page 30 of the kidney issue that talks about incidentalomas in the volunteers at the workshops, which I think is just such a great way to enter this topic. You mentioned 1 in 10 patients have a renal cyst. just curious, what do you do from a practical standpoint? You see a patient in the ER for, acute kidney injury, and they have hydronephrosis and distended bladder with enlarged prostate, let's say, this is going to get better over a few days with Foley catheter, and but you saw that they have an incidental renal cyst. What's your approach to that point of care finding? How do you inform the patient? How do you currently in your practice, how do you document that? How do you follow it up if necessary? Just as I know this is, I said before, we could talk an hour about incidentalomas, but it is something that's going to come up for anyone who uses ultrasound to evaluate the kidney. It's so common, 1 in 10 would have a renal cyst. So, what's your general take on that? And, it's obviously program dependent about documentation and image storage and those elements of it, but I'm just curious what you do.
Yeah, this was an excellent article, really a reflection by one of the fellows that I trained now, who works with Abi, Ira, I think is at your institution now, who
he's my colleague now.
Himself and found a cyst. He's like, oh my God. I know that, and to his credit, I think he fanned through it, in one axis. He rotated the probe 90 degrees. He looked through it in the other axis. He's like, this looks like a simple cyst. It's pretty big. He measured it. It's 5 centimeters, but there's no loculations. There's no calcifications. There's no internal echoes, no septations. Or like, we think this is a pretty benign looking cyst, but let's, I actually put in the order for his referral ultrasound, which is what we do in these situations where we, I think we could have probably gotten away with this one, not ordering referral ultrasound. But if you have any doubt, order that referral ultrasound, and know that for these for cysts in particular, if what you're not seeing is a simple cyst. If you see a lot of septations, if you see internal echoes, calcifications, or whatever, don't be afraid to order a referral ultrasound. Don't be afraid to order a more definitive test, a CT or an MRI, because ultrasound is ultimately not the modality of choice. I think it's particularly poignant to my own practice, because there's a law in my state regarding prompt notification of the patient in written and clear language. You are required by law to inform them of any incidental findings within a certain number of days. So that's extremely important, and something that our system-wide point-of-care ultrasound committee, which we're so lucky to have at my institution, has. The other two incidentalomas in that are of my co-fellow, actually, Bedad Besharati and close friend. We discovered that he has a pelvic kidney in another point-of-care ultrasound workshop, and I actually found doing some self-scanning that I have a junctional parenchymal defect, another very benign and common finding, but I think you do have to disclose these things. And that's part of something that Noel and myself get to in our nuts and bolts article. You need to have a system for disclosing that. You need to make sure you're teaching your fellows to order referral ultrasounds in the correct context there.
It's so helpful. It's a very important issue. It comes up. It's a national problem, but I think a local solution in terms of what the institutional or other policies are and practices around that. And I think it's also important for the non-emergency setting. So in critical care and emergencies, I think the idea that a patient who shows up in shock and hypotension, that incidental findings are I think not an immediate focus, but in a stable outpatient who you're scanning to look at kidney size or VEXIS exam or other things, that those incidental findings, are going to be owned by you, who found them. And I think it's great to have a plan in place that's strategic around that. For those who, are afraid of this. Incidental findings are not a reason not to do POCUS. It'd be like saying don't examine someone's thyroid because they you could find a small incidental nodule if you were trying to evaluate for a goiter. I think incidental findings are a part of imaging used this way, and it's good to be aware of them also as mimics of other illness. So I mean, cysts as mimics of hydronephrosis is an important distinction to be able to make at the bedside.
Absolutely, and I'd add just really quick, Charlie O'Neill, who we mentioned earlier, and Vandana and I are also at Emory. They've done tens of thousands of referral kidney ultrasounds done by nephrologists. They see renal cell carcinomas from time to time, and that's going to be a fact of life. They've never had a lawsuit from any of those tens of thousands of patients that they've scanned.
Yeah, that's helpful. I think I glad we could touch on it. We obviously could talk a lot more about sort of how to approach that big topic, but I do want to make time for you both to talk about sort of future directions, in nephrology and in the POCUN world, and what some projects maybe that you're working on, or future directions for research, but also maybe quality improvement, and then the point you made about our issue here is being listed over time at the Renal Fellows Network, but some other maybe upcoming conferences or ways that current non-nephro or some nephrologists who are not POCUS users, maybe how they would be able to get training, where they might do that as in the CME setting, at conferences or workshops. So take it away. Future directions.
Yeah, we have multiple POCUS workshops coming up. So there are a lot of people who just want to get some hands-on experience to begin scanning at their institution. They're just looking for someone to hold their hand and know the probe placement, and some are looking for better resources or just some lectures that are that will just create the initiation. And we have, I think, 3 major workshops coming up. One thing is KidneyCon. KidneyCon is organized by the NephJC group, or the National Nephrology Social Media Collective group, which is very informal and geared towards trainees, and it's very popular among trainees. So, but this year it's online workshop. So, and we have a half-day POCUS workshop, and we are trying to make it more meaningful, as useful as possible, by incorporating remote instruction on probe position and stuff. And the next, that's in April 29-30. And and there is a National Kidney Foundation meeting coming up. It's in the first week or the second week of April, and there we have a short workshop. It's only for about like 1 to 2 hours, but it's a good starting point to get the basic idea of the probe positioning. In November, we'll have American Society of Nephrology annual meeting, where Nathaniel and me are co-directing a pre-course on POCUS. That's going to be
week.
What?
Kidney week.
Yeah, Kidney Week. It's not annual meeting. Yeah, you want to talk more about that? That's really exciting.
Oh no, sorry, I interrupted. So all those, I think it's really great to get out and get some practical hands-on experience. Take that with you home, because the longitudinal experience is much more important. It's like if you learn a foreign language in an intensive course, maybe you go to the country, spend a few months there. If you're not practicing at home on a daily or weekly basis, you're going to lose all those skills. NKF, KidneyCon, and ASN's Kidney Week are all excellent opportunities to get some hands-on experience from our point-of-care ultrasound and nephrology experts. I'm really excited, Jamie, in particular about our collaboration, as we mentioned, with the Renal Fellow Network. So this is a network of blogs put together by Matt Sparks and other editors who are very prominent in the nephrology world. It's free, open access medical education, done well, and soon, as soon as we have put together all of these blog posts on our fellow created point of care ultrasound cases that we've just published in the POCUS journal, we'll have blog posts coming out here shortly. You talk about future directions. I want to shift focus. I think there's a lot of things that we've touched on now that are particularly exciting. I think we've in our lifetimes, we're just, me and Abhi, I think we're both just starting out. We're just a few years into practice now. We've seen the miniaturization of ultrasounds over time. Obviously, we've seen handheld and pocket ultrasounds. We've seen ones that work with your smartphone. We've seen the advent of cloud imaging, making it very easy to store and retrieve images and making the documentation very facile. So I think we're going to see increasing utilization over time. We've seen artificial intelligence also. We have an article on this from some med students actually who I collaborate with, Lam and Sanko and his colleagues here at Penn, are making, I think, more practical the VEXIS protocol, for instance. I think we're going to see imaging made much easier and in ways that we don't necessarily know yet. Already lung ultrasound, there are several companies which have artificial intelligence to enhance their lung ultrasound, and this is coming, I think, shortly to the VEXIS protocol as well. But I think I'm really excited for the future. There's a lot of other things which are coming out soon. I think the CMUT, the capacitive micromachined ultrasound transducer, also is a big revolution in point of care ultrasound. It's replacing conventional piezoelectrics, dropping the price another 5-fold. So I think we'll see what we've seen with IVUS, for instance. We'll see disposable ultrasound probes. We'll see ultrasound probes that you can use like EKG stickers in the future. So I'm really excited about the future of point of care ultrasound.
Wow. This has been such an amazing opportunity for our listeners to hear from two visionaries in point of care ultrasound and nephrology. And the issue you put together is really a testament to your joint shared passion for this movement. And we're so grateful to have this issue, the kidney issue of POCUS Journal, available on POCUSjournal.com. We're so lucky to have you, and so grateful that you put in so much work to make this happen. And we're also just so fortunate to have you on the board of POCUS Journal for future kidney content, and to hear from you today. I just want to thank you again both for being here, and again, point our listeners to the website where all these articles are available for free. So thanks again.
Thank you. It was a pleasure.
Thanks so much for having us, Jamie. I really appreciate it.